Welcome to another edition of the Inspired Stories podcast, where leaders share their experiences so we can learn from their successes and be inspired by how they've overcome adversity. My name is Anthony Codaspoti, and today's guest is Dr. Kintur Sanghvi, Chief of Cardiovascular Intervention at Virtua Health. They are an academic health system in South Jersey that offers a full range of services from heart care and cancer care to urgent care and more. Their mission is to help people be well, get well, and stay well. And they're known for their innovative outreach programs like a pediatric mobile services unit and the Eat Well initiative. Dr. Sanghvi himself has been recognized as a top doctor by New Jersey Magazine, Philadelphia Magazine, and South Jersey Magazine. He has performed over 13,000 cardiovascular procedures, authored multiple research articles, and is a professor of medicine at the Virtua Rowan School of Medicine. He has shared his expertise across 5 continents and pioneered the use of wrist and foot arteries for catheterizations. He also serves as director at the Virtua Lourdes Cath Lab, where he continues to advance patient-focused innovations. Now, before we get into all that good stuff, today's episode is brought to you by my company, Add Back Benefits Agency, where we offer very specific and unique employee benefits that are both great for your team and fiscally optimized for your bottom line. One recent client was able to add over $900 per employee per year in extra cash flow by implementing one of our innovative programs. Results vary for each company, and some organizations may not be eligible. To find out if your company qualifies, contact us today at addbackbenefits.com. All right, back to our guest today, the Chief of Intervention Cardiology at Virtua Health, Dr. Kintur Sanghvi. I appreciate you making the time to share your story today.
Anthony, thank you so much for the opportunity to talk to you and your audience, and hopefully share our journey of innovation and taking care of patients and be inspirational to each other. This conversation should be.
Looking forward to it. So, Kintur, you've now done over 13,000 cardiovascular procedures. You've trained more than 100 cardiologists, launched multiple programs across major hospitals, and you're helping to shape what the future of cardiovascular care looks like. But I want to go back a little bit to the beginning for a moment. You were 23-ish when this all started. 23 and completely locked in on cardiovascular medicine. What sparked that focus for you? Was there a moment or experience that kind of lit the fire for you?
We started medical school back home in India at right after the high school. And having an immediate family member, my mother suffering from heart valve disease, my focus was on cardiovascular physiology and anatomy, more so over the other system, because your immediate family member has some history of cardiac condition. And as I graduated from medical school, around age 22, I would say, I had a unique opportunity to work with a cardiologist right out of my graduation as a junior medical registrar. And there it was very obvious that this is what I want to do. And that spark happened from about 36-year-old guy who had 2 kids, who present, I still remember his face because it was the first patient that really kind of locked me in to do cardiovascular medicine, and particularly interventional cardiology, who came in cardiogenic shock. That means the heart rate was low, the blood pressure was in 90s. He had a major heart attack. When he was in the emergency room, he coded. We had to do CPR briefly, came back, and then the cardiologist who I was working with went in and put a stent in his main artery on the left side called left main artery, also known as widowmaker. And, this is all transpired within time of 25 minutes or less. He fortunately presented in the daytime while we were all in the lab, and almost somebody who died in front of my eyes as a very young doctor. Next day, I was holding his hand and have him walk. And seeing at that time he had like 2 young kids. This was a very, very rewarding part of practicing medicine. Everything we do in medical science does not always yield prompt and solid results. If you look across all the different subspecialty, this one was very appealing because it was, wow, this immediate response. And from that day on, so it was like early on, I was locked in because of that particular two reasons that I mentioned.
I have to imagine that was an emotional experience to be a part of for the first time.
Absolutely. Absolutely. When you are a new medical student and then you graduate from your clinical rotations and now you're in real field and everything is very complicated at that time. Everything is very difficult. And in that situation, a quick diagnosis, quick response, quick treatment, all overwhelming. Still remember it.
Yeah.
As if it was yesterday.
Does it give you goosebumps still to talk about it?
Yeah, sure. Absolutely. Probably you can sense it.
Yeah. So then, after your training, you spent over a decade at a major academic hospital in New Jersey. You're publishing, you're teaching, performing thousands of procedures. What do you remember about some of those early years?
My journey was definitely not easy. Was difficult, but I would say that after graduating the Interventional Cardiology Fellowship, the first year as you go out in the practice, and now you're on a first call and the patient comes in with, as I said, heart attack, cardiogenic shock, and somebody who had CPR in the field, things like that. It's very, very unnerving, even though you are trained for it, the day you are taking responsibility of a human life in front of you, and also understand it's not just one person, it's the whole family and everything that's connected with that person. It's definitely unnerving and challenging, but I was very fortunate to have lots of great teachers across my career, great inspiring human beings around me, and I felt very comfortable and confident from day one when I went out. But everything, life takes you places, and the journey that you go through, it's kind of you don't know what it's going to lead to. But interventional cardiology field, if I think of early days of my after fellowship finishing, being part of a tertiary care academic place, being involved in the cardiology and interventional cardiology fellowship programs and their training and their upbringing really makes you better at everything you do, because you're now going to think through on every aspect of patient care. And that makes you mature because you're going to teach somebody. You want to make sure you learn from that process. And when you're teaching somebody, you want to teach that right. So I think that played a huge role in where I am today, is that interaction with the medical students, residents, cardiology fellows, and interventional cardiology fellows, and constantly getting involved in teaching and sometimes getting inspired by them, sometimes helping them bring idea to a fruition and getting a research idea executed and get it to a publication. That the entire journey kind of makes you get involved 100% on everything you're doing on every day. So I would say, if I, at a high level, if I think of those early days, I would say that was like really fun time. A lot of new learnings. We did a lot of new programs, new procedures. This is also the time when interventional cardiology field evolved through a lot of new procedures. So we adapted some of this new. Some of them we were able to lead the revolution or evolution. So it was great days. I was very involved in what we call trans-radial approach. So doing catheterization through the wrist instead of groin. And again, that's something I can think of early days that was really...
Say more about that procedure. What was your level of involvement and how did the idea come about?
So I did my first trans-radial, the wrist catheterization, in 1999 back home in India. The cardiologist with who I was working with in the cath lab those days learned this approach from a Japanese cardiologist named Dr. Saito. So Dr. Patel, Tejas Patel, my mentor back home in India, and we kind of wanted to bring this approach because it was a safe approach. We did not think that we can easily do this catheterization procedure that we used to do from the groin. Um, and it seemed that would be very safe for patient, because it is the anatomy. The groin artery is much more vulnerable for bleeding complication after the procedure. So if you do any catheterization procedure from the groin, irrespective of your level of training or experience, it's just the anatomic variation and the location of the artery with the room for bleeding inside the stomach called retroperitoneal bleed and inside the thigh can lead to large hematoma. So a lot of patients in those days, in 1999 to 2004, I would say, if you look back to the history, there was a high mortality associated with this complication. So you do a very important procedure. You open up somebody's blocked heart artery, but then the patient ends up suffering from the bleeding, or even sometimes you lose the patient from bleeding and pseudoaneurysm. Versus the wrist artery, which is sitting right in front of the bone, which is having a collateral circulation. That means this is not an end organ artery. If the groin artery gets closed, your leg can get infarct or can get gangrene, or you can lose the leg. But here, if the wrist artery gets blocked, there is a collateral circulation that continues to perfuse the heart. So perfuse the hand, I mean to say. And the easy of compressibility against the bone and stopping the bleeding right after the procedure, in compared to the groin where it is difficult. So it was coming up from evolving need of patient safety. We got better at balloons, we got better at stents at the heart artery level, but we did not improve anything from where we enter the body and how we reach to the heart. And that's how it started. And then, I was involved early on. So I was very involved in bringing that procedure to America in a way, through my fellowship, through my mentors here in America, Dr. John Coppola, Dr. Cindy Grimes, the places where I went for fellowship. I had them come with me back home to India and do procedures with my mentor, Dr. Patel, in India. So they will do like 200 wrist catheterization in 2 days and bring that technique over to America. And that's how the spread happened. That the radial procedure spread happened through St. Vincent's Hospital in New York City. And then we continue to experiment and understand, as going through, what are the difficulties. There is a variations in the anatomy. How can we reach to the heart safely? How can this become as good and as safe as the groin procedures? Can we do it just in a regular cases, or can we start doing that for heart attack patients? Can we do it for complex coronary blockage and blocking? Should we start doing it for leg artery blockage or kidney artery blockage, or should we start doing what we call structural heart intervention? And that's how things evolve. And that's where I was kind of very much involved in trans-radial peripheral interventions. My first paper was in 2007 about doing trans-radial iliac artery intervention. That means the arteries between the belly button and the hip joint. And then trans-radial structural interventions, trans-radial use for complex coronary interventions. We did research on what happens to the wrist artery after the catheterization. What can we do to preserve the integrity of the wrist artery? We came up with the design of a sheath or the access that is specific to the wrist artery. We came up with the design of the wire that is specific to the working through the wrist artery. I had a couple of my own patents in this area from my research and from my learning on how to improve the access from the wrist to go to the heart. Something called railway sheathless access system, which was Cordis Johnson and Johnson worked on that product idea, and it's now available across the world. Then there was a short and tight tip wire that I was involved in developing. So the things like that played a role in evolution of the radial approach.
So let me hop in here, because there's a couple of interesting things at play here. I think one, to sort of zoom out, especially, being based in the US, I think a lot of times we think, oh, all the world's innovation comes from here. But this is a great example of, it's a Japanese doctor who first came up with this procedure. It was really being advanced in India, years before the US had adopted it. You played a big role in, taking doctors to India, say, hey, look, this is better. Look and see how they're doing it. But then, as you're talking about this, I'm like, oh, so you didn't come up with the procedure. What was your involvement? And then, you answered that, which was, man, there's a lot of like fine tuning, like, what's the correct way to enter the wrist, and the different anatomy that we run into in there, and the patents that you came up with to kind of improve that process. And as I heard you kind of explaining all of that, you're also talking about entering through other points of the body. So are there times where the wrist is not the best entry point, even though that this has far fewer complications than entering through the groin?
Yeah, absolutely. There are patient situations where wrist is not the best. Sometimes the wrist artery is very small. People who have a dialysis needs, they may be needing fistula for dialysis, and you don't want to enter the wrist artery and disrupt that wrist artery. So there are definitely clinical situations where groin artery access is superior. If we want to use large device, for example, now we do transcatheter valve replacement. It's a very large device. You cannot get through the wrist artery to get that kind of device. So but let's say if we dial back, in 2008, the first what we call NCDR database paper that talked about radial was published by a guy from Duke University. And at that time in America, only 1% of the catheterization procedures were done through radial approach. Today, that number is in upward of 50%, almost 60%. And
do you think it's not closer to 100% because still there are some people who don't know about it? Or is it because 50% of the time it's the right choice and 50% of the time there's a better choice for that particular patient?
I think it's still not there because of people who have not got themselves into doing it. Some of the older physicians who started at the groin did not evolve into using radial. There are multiple factors behind it. But if we look at ourselves and compare to other part of the world, and I want to correct just a little bit, the trans-radial procedure was really not invented by a Japanese cardiologist. Okay. It was first described by a Dr. Campo in Quebec City, Canada. And then in 1993, that was for a heart catheterization. And for 1993, first angioplasty paper was described by a guy from Netherlands. But if we look around and if we kind of look back in the history, there are about 6 or 7 guys, or maybe 8 guys who played a huge role in spreading this technique across the globe. And Dr. Saito and Dr. Patel, along with probably Dr. Yves Levard and a few of the other names that I mentioned, are probably part of that.
And I'm glad that you mentioned that. It just shows the value of this kind of international collaboration and moving new ideas forward. As you were trying to introduce this to more doctors in the US, did you run into resistance from folks that are, part of the old school, this has worked forever kind of a thing?
Absolutely, yes. Absolutely, yes.
How do you overcome that?
So, first, you need to have a clear understanding why you are doing something. Is that, when you have a right objective, the objective is very clear. It's a patient safety issue. There is reduced complication. Does not matter how good of an operator you are. It's about the anatomy, the safety of the anatomy, right? So when the patient safety is your most important priority, people will get you eventually. It's not about your ability to do something superior to somebody else. It's not like that, right? So first, that was one thing that played a huge role. Second thing, the staffing. When the staffing's buy-in came in, the staff really thought, "Oh my God, why are you doing this? Such a big use." I can tell you some of very well-known physicians in our field. In conferences, when if I talk about excess-related bleeding, will say, "Why would you go to this small wrist artery? There's a huge pipe here in the groin. We have closer device. We have a medication called bivalirudin or Angiomax that doesn't allow too much bleeding. Why would you struggle to go through this wrist, right?" And so there was resistance all over. But eventually it became a staff involvement that staff said this is much better for patients. They don't have to hold the groin for hours. They don't have to worry about bleeding as much. They don't have to run them or wheel them to CAT scan for ruling out bleeding in the groin. It is so simple for patients. They can sit up right away. For our catheterization done through the groin, you have to lie flat for 4 to 6 hours. Versus when you are doing it through the wrist, you can sit up right away. You can eat right away. You can even walk. And there are centers in many centers in the world, they don't even have the patient undress below their pants, and they just prep the wrist, do the catheterization, do the stent, and in an outpatient center, they go do the stent procedure, go sit in a chair for 6 hours, recover, and go home. So, the staff really started like it. Patients started seeing it. Patients say, "Oh, why do I have to lie flat while the other guy is sitting next to me is sitting up?" So patient drove it. So nothing happens over time. It takes the spread of innovation takes years, and it took its own course. There was like a point of chasm from which the spread happened very fast, but in early adopter being in the first 3% of the operator across the globe to start this procedure and to bring it to now where it is, it the initial phase took a longer time. From the point of chasm, it was a faster spread, and then people trained each other. And I think it's a very good thing that happened in our field, which has translated into improving mortality and morbidity for countless lives, I can tell you.
Do you have any idea what the stats are on that?
Difficult to say, but I can tell you from major studies that nearly, let's say, 1% versus 0.1% risk of bleeding. If you talk in pure statistical terms, it's almost nearly 100% or 90% improvement in access-related complications.
That's amazing. And you've been involved in a number of other innovations. We're going to talk about one here in a moment that just received FDA approval. But before we do that, I'm kind of curious to get your perspective on, from having been through this multiple times, is there something that would help speed up the adoption of these new technologies? I mean, human beings, by our nature, we're resistant to change, right? Hey, I'm comfortable. This is the way I've always done it. This is the way I was trained. But is there something in your experience it's like, oh, if we could turn this one dial or flip this one switch, or it would help speed up the adoption of these new technologies?
So it's a very good question, Anthony, and I think about this a lot because everything that we do, every new information has this time to spread. And from, again, a personal experience, somebody very close to me in 1980 died a premature death from cancer because there was only one CAT scanner in the entire state back home in India, my state where I grew up. And the technology, while it was available, let's say in America at that time for early diagnosis, it was not there in India, right? If it was there, it could have been a different thing. So if you look around and if you look through the stats, the number of people they lose their lives or they suffer because of lack of spread of innovation, know-how, technique, or technology across the globe plays a huge role in mortality and morbidity. For simple example, for anybody to understand, some countries in the world today even don't have the most life-saving vaccines, such as polio, not given to their kids, right? And so there are multiple factors, and some beyond your capacity, the geopolitical issues and all those things, right? But if you look at the spread of innovation at every step of the way, whether it is innovator, early adopters, point of chasm, mass adoption, one thing can play a huge role, and that is education. Education and awareness in each of this stage can speed up this whole curve of spread from over 20 years to maybe 15 years or maybe 12 years if the education is powerful. And I think we are in that space now. We are on a space where there is an over information bombardment. So there's so much information hitting us from all over the place. But we are also in a situation where the information and knowledge can spread much faster with the global connectivity, with platform like what you are doing, like your podcast, right? Is going to connect so many people and bring them to awareness. So I think this right now we are at also point in the history of human race where our access to tool to help spread this fast is there if we use it right.
Mm-hmm. I want to talk about another technology that you've been involved with, and this is more timely. Renal denervation. I understand recently approved by the FDA. What is this? What's the problem that it's helping to address?
So it's going to be a little bit of a long answer, but let's define that first. What is renal denervation? Renal denervation is a catheter-based procedure, a minimally invasive procedure, a same-day procedure, in which we go to the kidney artery using a catheter and using technologies such as ultrasound or radio frequency energy, we tone down the overactive nerves that travels on the outer surface of the kidney artery. So there are nerves that are traveling on the outer surface of the kidney artery. They are called renal nerves. And these renal nerves are what we are denerving. That means we are toning them down. We are reducing their activity by using a catheter from inside the kidney artery and using the energy in the surrounding space around the kidney artery.
So, what is the problem with the nerves being too active? What is that triggering?
So first question was what is renal denervation? So I explained the procedure. What is it trying to address? That's a longer answer. What it's trying to address is the high blood pressure. There are many chronic illnesses for us, such as, and we're going to focus on high blood pressure right now, but there's also diastolic heart failure, sugar control, sugar resistance or type 2 diabetes, obesity, obstructive sleep apnea, heart failure, arrhythmia. There are many other conditions that are associated with this overactive nerves. But we're going to focus on high blood pressure because high blood pressure is the number one cause of death and disability. When we wrote the guidelines in 2017 November on the update of the high blood pressure guideline, the driving principle was that high blood pressure is number one cause of death and disability for human race.
Wow.
And imagine that hardly, I would say, 5 out of 100 people will think it that way or know it that way. Okay? And the reason is, number one, it's very highly prevalent condition. Every second American adult is suffering from high blood pressure. Okay. Worldwide, about 1.8 billion people suffering from high blood pressure. So that's number one, the prevalence is high. Number two, high blood pressure over the years affects multiple organ system. It causes effect on the heart artery to increase the risk of having heart artery blockage and its related problems such as heart attack. It can affect the artery to the brain, cause blockage, and also cause bleeding in the brain and causes different kind of stroke, hemorrhagic as well as ischemic stroke. So either bleeding in the brain or lack of blood flow to the brain that leads to stroke is one of the main causes, high blood pressure or uncontrolled blood pressure. It causes thickening and stiffening of the heart muscle and causes what we call diastolic heart failure. Eventually, if heart continues to work against this high blood pressure, this muscle gives up, become dilated, and the contraction becomes weak, and it's called systolic heart failure. It also leads to gradual decline of the kidney function. Number one cause for medical renal disease or failure of the kidneys is uncontrolled blood pressure. So people with uncontrolled blood pressure are very much more likely to get dialysis and go on to kidney transplant list. It also affects the memory issue. So there is now clear evidence people with uncontrolled blood pressure are more likely to have dementia in their later age. People with uncontrolled blood pressure are also likely to have arrhythmia, such as atrial fibrillation, ventricular arrhythmia. Number one cause for atrial fibrillation across the globe is hypertension and not valvular heart disease. So high blood pressure affects the multiple organ in a negative remodeling or negative way over the years. The problem is this disease does not cause symptoms. So 1 in 3 people who are having high blood pressure don't even know they have high blood pressure. 1 in 3 people who know that they have high blood pressure cannot get their blood pressure under control because to date, whatever is available, all the medications, they try medications and despite that, they don't control blood pressure. They try medication, they have side effects they cannot tolerate. They keep on changing the meds because of side effects and they cannot control the blood pressure. Right? So it does not cause symptoms. It's highly prevalent. It affects the body day to day, every day. When you are talking to me right now, and if your blood pressure is 140 versus mine is 120, over next 3.4 years, from data, if we extrapolate the data from a trial called Sprint trial, which was a randomized prospective sham control trial, if we look at that trial data and if we apply the data in next 3.6 years, your chances of suffering a cardiovascular event is significantly high, almost double than mine.
Wow.
Okay. But the lack of awareness of this condition, lack of awareness of this implication, and as I said, it's not going to cause you headache. If you got a headache, I'm going to take Tylenol right away. But if you don't have a headache,
You don't even know what
you may
are you
not
going
take
to
the
do?
medicine.
Yeah.
So that's the other problem, that people are not compliant to their antihypertensive medication. So you are a good patient, you take care of yourself, you go preventive care, you go to your primary care doctor. He says your blood pressure is high. I think you need to start taking blood pressure medicine. You are 140. I prescribe you medicine. I'm your primary care physician. Let's say, for example, 50% of the people stop their antihypertensive medication in the first year of their prescription. So
why?
when you
Because of side effects or just general
side
non-compliance?
Number one, side effects. Number two, the disease doesn't cause symptoms. Day to day, to remember to take a medicine as your routine and be committed to it, if you don't have enough education and awareness that what it is doing to your body, you're not going to do it. So,
sorry, doctor, what is the root cause of high blood pressure for most folks? Is it diet, too much sodium? Is it, carrying too much weight? Are those risk factors there?
So all of them play a role. But one of the things that we have known, so when I went to medical school in 1990, we were taught it's something called idiopathic hypertension or essential hypertension. It's something we don't know what causes high blood pressure, but it's there. There has been genetic predisposition. There has been clear establishment of that. But one thing that we always thought that, it's idiopathic or it's something causing it, we don't know. We have clear understanding that sympathetic nerve overactivity plays a huge role in causing high blood pressure, whether it is associated with genetic predisposition or whether it is part of our current lifestyle, our current societal lifestyle. But the sympathetic overactivity, so the body's fight and flight response, comes from the sympathetic nervous system, and that sympathetic nervous system overactivity plays a huge role, and that is why renal denervation. So one of the root cause of this is the overactivity of sympathetic nerves. Now, does diet play a role? Absolutely. Overusing of salt, processed food, junk food that tastes so good, does that play a role? Absolutely, yes. It does play a role in causing high blood pressure. Utilization of alcohol, frequent use of alcohol, tobacco use, overweight. These are all very well known cause hypertension. But at the root cause is this sympathetic nervous system. Now there are some other causes, something we always learn as what we call secondary causes of hypertension or secondary hypertension. That means something is causing high blood pressure. For example, overactive gland that is secreting too much hormones such as epinephrine, norepinephrine, adrenaline, or renin or angiotensin. Those kind of over-secreting of hormone can cause high blood pressure, but that's a very small number of patients that suffer from secondary hypertension. The less than 5% of the people who have high blood pressure has a known or established cause other than sympathetic nervous system overactivity that causes high blood pressure. But for everybody else, sympathetic overactivity is very important or integral part of the cause of high blood pressure. Now, if I can take 2 extra minutes or maybe extra minute to explain what is sympathetic nervous system.
Yeah, is this related at all to the vagus nerve? I hear a lot of people talking about that. Are these connected?
They are connected. Everything is connected. The whole existence is connected. The whole body is connected. Every organs are connected with each other, and they all work in sync.
All right, enlighten us. Yes, please.
They get better.
Yeah.
But the nervous system, the two part of nervous system. One is somatic nerve. So when you thoughtfully move your hand or you feel the touch, you feel the temperature, you feel the pain, that's all come from somatic nervous system. That all goes to the spinal cord, into the brain, to the conscious brain, and you perceive and you respond. That's the somatic nervous system. And the second is the autonomic nervous system, which is a lot of things happen in the body. While we are talking and consciously conversing, Our heart is beating, our lung is breathing, maybe the food that you consume an hour ago is digesting. This is so much process. The wastage is being discarded through the urine formation. The blood is flowing through a million mile long blood vessel, I would say, because in the body, if you really put them together, it's a very, very billions of capillaries or microscopic
And none of these
arteries.
things we're actively thinking about or initiating ourselves. Our body's just doing it in the background automatically.
Absolutely, yes, automatically. And that automatic regulation of all the organ is conducted by autonomic nervous system, which has two components. One is the vagus nerve. That's the, like for every yin, there is a yang. So vagus nerve and sympathetic nerve. Sympathetic nerve is a stimulator. Vagus nerve is a calming down nerve. So when you do yoga, meditation, you are activating your vagal tone. So you are having a calmer response to things. Your heart rate slows down with that. Your respiratory goes down with that. Versus sympathetic nerve, you say, I had an adrenergic drive, so I did this and did that, and I accomplish some most non-achievable task because you are on a go, go, go. Your heart rate is working harder. Your all organs are working at a faster, higher paces. So that's the sympathetic nervous system, and there is a control that should happen in everybody, nature's design. But this control system, the negative vicious cycle of overactivity of the sympathetic nerve, is what drives the high blood pressure.
And so now the recent FDA approval is this a device? Is this a treatment? What is this? What does it actually look like?
There are two devices. These are very small, about 2 millimeter or smaller diameter device that goes to the kidney artery and performs the action. One is an ultrasound denervation device that is approved, which emits ultrasound energy, sparing the artery and the artery wall by a balloon that cools the inner surface of the artery and then spreads the ultrasound energy 360 degree in the surrounding of the kidney artery. And that's how it basically disables the nerve by making the outer layer of the nerve dysfunctional. And that's how basically it makes the nerve dysfunctional completely. It's called perineurium. And then the second technique is the radio frequency energy, which is again a device that is about 1.4, 1.6 millimeter in diameter. It has a nickel titanium alloy with electrode on it, which basically converts electrical energy into radio frequency energy. And it spreads the radio frequency energy at the point of contact and in the surrounding area through what we call adipose tissue or a fat tissue heating. Any nerve that is traveling inside that becomes dysfunctional or reduce it. So by reducing the sympathetic tone, it translates into controlling the blood pressure.
Fascinating. So with recent FDA approval, how long before a patient could actually have access to this?
In fact, there is access to the patient now in probably, I would say, every state in America.
Really?
The approval happened in October, November of 2023. Right now, the last year was the phase of post-approval evaluation, and in that there are regulatory agencies that goes through the approval process for reimbursement and stuff. So 2025 January, Medicare approved what we call transition payment or TPT. So the current issue is that many insurance companies and but not reimbursing for the procedure. So that was our one of the dissipation of innovation limitation, as I said, geopolitical and a lot of different things as a system-based problems. So, but that's the situation right now. January 1st, Medicare approved the TPT. Right now, it's being considered for payment for the procedures and all that by insurance companies. So today, if somebody's suffering from high blood pressure, we can still treat them, work through their insurance company, try to get prior authorization by appeal process, and we treat them. If they are Medicare patients, we can treat them through what I just described. But that's if we don't consider as the limitation right now, is renal denervation treatment available across the United States? I would say probably almost every state has at least one center which can offer this treatment.
And In what use cases is this better than the current treatment? Is it better for everybody? Is it better for people who don't respond or have side effects to the current approaches?
Anthony, you're really asking very good questions. Okay, um, so uh, it's not for everybody. This is a new treatment. We have time tested treatment as medications. Medications are being used for over 70 years. Of course, we don't have a new class of medicine in the last 25 years. There is no new innovation in hypertension care in the last 25 years. And this was very much needed. There was like a definitely a need for new treatment for high blood pressure. But there are multiple classes of antihypertensive medications that are available for many years. So the first line of treatment is your lifestyle modification. If you can quit smoking, if you can reduce the number of alcohol intake or the drink you have, control the salt intake. There's a diet that has been very well studied. It's called DASH diet that is translated into reducing the blood pressure as much as the medication will do. Regular aerobic exercise, regular aerobic activity, yoga, meditation, all this has been proven in multiple different studies that if you adopt some of this lifestyle, it can help improve your blood pressure control significantly. So the first line of treatment today is lifestyle modification. The second line of treatment is the medication. As I said, there are multiple classes of medication. One might be better than other for you, depending on your race, depending on your age, depending on your coexisting current comorbid conditions. Like, if you have diabetes associated with versus if you have heart condition versus you are, let's say, African American versus white origin, one class of medication may work better than other for you. But the medication is the second line of treatment. People who cannot tolerate medicine, who have tried medications but cannot control their blood pressure. So something called failure of treatment. Then there is something called resistant hypertension, where people are taking three classes of medication. They're taking three different medication. They are regularly taking their meds. They're very compliant to their medications. They have tried their diet, exercise, etc., whatever the best they can do. Because, idealistically for a physician, it's very easy to say, do exercise, do this, do that. By thinking also, one can say, yeah, I will do that. But executing that on an every day in a current societal lifestyle that we live in may not be for everybody. So you have tried your best that. You have tried medication, so you're taking three classes of medicine, but your blood pressure still remains uncontrolled. It's called resistant hypertension. That means the blood pressure is resistant to the current form of treatment. So those are very good patients to consider this treatment. So resistant hypertension, people who have tried and failed the treatment or they cannot tolerate the medication. Can a young person think of this as an alternate to blood pressure medication? Can I, let's say I'm now 40 and I need blood pressure medication. I'm concerned about side effect and taking it every day. Can I try this procedure? The clinical trial supports that. Clinical trial says, yes, these patients are more likely to respond to renal denervation in compared to people who are in their 60s with multiple medication. Okay? But currently, do we recommend that to young people? No. We still say that go for lifestyle and medication is your first line of treatment. It changes in case if you suffered an event. So let's say if you had a heart attack, you had a stroke, you had a heart failure, you had arrhythmia, you had a kidney failure or kidney function going down, not necessarily completely faint kidney, but your kidney function is declining because of uncontrolled blood pressure. In those patients, we recommend they should go for renal denervation.
Because they need a quicker fix. They're more at risk.
They've already showed us. They already showed us that, look, I'm suffering. You got to do something. Whatever you have done so far has not worked. So those are the third group of patients that I would say we want to offer them treatment right away.
Are there any known side effects to the renal denervation?
Once again, very good question. You're talking like you're a patient. So the procedure was deemed very safe. When FDA panel, I was fortunate to be part of the panel presenting to the FDA panel about our findings from research trials on renal denervation. And I can tell you this panel is solid. This panel that FDA convened for both the devices presentation, they're like some geniuses who have done 600, 800 publications from across the globe. FDA put this panel together who are really objectively examining every point of data that is presented to them whether they should approve this device for treatment of high blood pressure or not. And one thing that was unanimous, all these people who were there, that this procedure is safe based on the clinical trial data. The risk of any major side effect or complication was less than 1%. The main complication was the access-related bleeding for the groin. So right now, this procedure we can only do through the groin approach. But as you can imagine, evolution continues. Very soon, we'll be doing this through the radial approach. There are device iterations and all that being considered. Delivery systems are being considered, and all that I'm sure will happen one day. But right now, we do it through the groin, and the common most side effect was associated with the groin access-related bleeding, which is about 1%. The risk of any effect to the kidney, we were concerned that would this require multiple procedure? Would this, because nerves do regenerate, would the nerves regrow again and they will require another procedure? So far, we don't see that. On the contrary, we see that there is an incremental effect. If you look at the 3 years graphs, so we have 36 months data from multiple trials that shows that persistently there is a reduction or maintained reduction of the blood pressure at 3 years. The third concern was that what if we change this nerve physiology for the kidney? Would the kidney function decline? And we have data that at 3 years, the kidney function remains same. So we look at what we call glomerular filtration rate or creatinine level. So there are parameters that we evaluate the kidney function with, and the kidney function is not changing over 3 years. So there was a rare side effect of the artery where we are putting the catheter and this device through. Can we traumatize that artery? And there was about 1 in 900 to 1,000 reporting of requiring additional procedures such as a stent placement if there was a disruption of the kidney artery. So those are the potential side effects.
This is a crazy idea and a very selfish one, but as somebody who's suffered from kidney stones before, I wonder, could this device in a different frequency be used to help prevent the accumulation of the calcium oxalates in the kidney there? I know that's outside sort of your area of study or expertise, but it occurred to me, so I have to throw it out there.
Yeah, no, I don't think so.
Okay.
This energy is not at a level where it can break the calcium oxalate stain. If we use that, it has to be used directly next to it. And you have to always think that everything that we do comes with. So as a physician, I always say to my patient, always say to my fellows that everything that we do comes with a price. There's a good and the bad. And that's why the Hippocratic oath of do no harm, because everything that we do can come with a harm. So if you think about this ultrasound energy or radio frequency energy, if we use in too much high frequency, it can start affecting the surrounding organ. It can cause strictures. It can cause effect on the intestine. It can cause effect on the kidney medulla oblongata or the functional unit of the kidney. So no, it's not.
Okay. Fair enough. I had to plant the seed just in case.
That's just how the innovation starts.
Yeah. Crazy ideas out of left field. And we've got a few minutes left together. And I want to make sure we talk about, with your experience, Dr. Sanghvi, probably work in all kinds of places. Lots of places would be lucky to have you and your skill set. How did the opportunity to join the Virtua Health system come about? And why did you choose to plant your flag there?
I think the more than important question of how did the opportunity came about, I think why I decided to join is a more pertinent question. And I think Virtua is going through a transformation. Being in New Jersey since 2009, knowing a little bit about Virtua Health, because Virtua Health was a small community-based organization, but they had a solid connection with their patients. Their solid, good quality clinical programs and solid financial practices. So the organization grew organically very fast. So in 2017 or so, I believe, they built a new hospital in Voorhees. Now, at this point, they are still a community organization. In 2019, they buy Virtua Our Lady of Lourdes. It's a tertiary care hospital with open heart surgery license. In New Jersey, there's a certificate of need to have an open heart surgery program. And you cannot open a new program because you want to. You can only get if the state approves that. So they acquire this hospital as a tertiary care. In 2023 January, they took over the Virtua Rowan Medical College. So if we look back, what they came in with is they had a solid, foot on the ground connection with the community, well recognized in the community, sound financial practices. From there, they grew, and they're going through this what from top down the system says is the academic transformation. Um, so, and if you can see that journey back, so I was entering at a point where it's the early adoption is done, and now I'm almost at a point of chasm where I can now grow multiple multiple research programs, initiatives, and there's a perfect ecosystem and there's a perfect opportunity. So it was, for me in my career, was perfect opportunity because what Virtua is doing as an institution, what I was seeing on a sideline, how they grew from 2010 to now, and it made perfect sense for me to be part of this organization.
What is it that you're most excited about at Virtua being a part of going forward with them?
I think the solid presence across 3 county, large volume of patient, a very organized systemic leadership where there is a proper chain of command with the proper directions and a unified approach to clear objectives and clear goals. I think those are all very solid, positive things for organization to have, and I'm very fortunate to be part of it.
Do you attribute all of that recent growth in the last 10 or 15 years to the leadership that's there? Are there other factors that are kind of at play that has allowed for this accelerated growth?
Honestly, I am not sure if I do have a complete vision to kind of really answer that question because I don't like to answer a question if I don't have clarity.
I appreciate that. That's rare in today. So, tip of my hat to you for that one. Um, let's see. We've just got about 5 or 10 minutes left. I guess we'll kind of wrap up with this question. But before I ask my last question, I like to do 2 things. First of all, I like to invite everybody to hit the follow button on their favorite podcast app so they can continue to get more great interviews like we've had today with Dr. Kintur Sanghvi from Virtua Health. And I also want to let people know either the best way to get in touch with you or to follow your story, doctor. What would that be?
Um, to for patient encounters or for somebody who wants to get an opinion for their healthcare from virtua.org or Virtua Health website, you'll be able to easily find the lead to get an appointment. Um, um,
Is there somewhere like if people are interested in kind of the innovations that you're a part of and kind of following more of that story that they can look for that info?
Yeah, so we do have our organizational website which talks about the research that we are doing, but I'm also kind of active a little bit on the social media for any important innovation that's happening in our field with the Twitter and LinkedIn.
Okay, great. We'll look for your profiles and include those links in the show notes. So I think maybe where I want to kind of wrap up today, Doctor, we've got to touch on just a couple of the innovations that you have been a part of. Is there something else that's brewing, that's in the works that maybe you're particularly excited about or that's coming that you want to give voice to?
Um, I think the right now, the use of the technology in improving the procedures, improving the access to the patient, early diagnosis of underdiagnosed, undertreated problems is something that right now I'm really kind of focused on and excited about because the goal is health and people who are not diagnosed or not aware of their problem and their consequences, if we can, when there is a evidence-based support to that, identify and treat them and prevent the consequences. So just for an example, at Virtua Health, people who did not have colonoscopy as a preventive care, X number of people were given a letter because based on the AI search that they did not have that. They were sent out information. Some of them chose to do it. From, let's say, about 1,000 patients chose to do the colonoscopy. 250 of them were identified to have a polyp that could have grown into cancer, and it was removed and neutralized.
Wow.
Right. So that's just the most simple example that I'm giving, that can be understood by anybody. But in our field, in cardiovascular medicine and interventional cardiology, there are many other things, and we're working on that. So I think that's very exciting.
What do you think are the biggest levers to pull to get sort of increased, improved diagnosis levels? Because I mean, every time I go to my doctor, heck, even my dentist, they take my blood pressure. And so like, that's a point of reference for me. Oh, still good, still good, still good. But clearly there are people who are not even taking those steps. And so how do you reach those folks? Do you have any thoughts on that?
Uh, Difficult, but it has to start at an early age. In my, and I think it is being done in overall U.S. education system. I hope we bring back the focus again a little bit more, because like everything else, on depending on the need of the time. For last few years, our focus in the education system was on different things, but I think the chronic illnesses, the cancer, the heart attack, the stroke, the high blood pressure, the diabetes, and early on education of good lifestyle, good diet, activity that is good for physical and mental health, and awareness starting at an early age would be the best way to do it. That's the only thought I have. Again, beyond that, I don't have much clarity to kind of say how we can bring population on board.
Yeah, it's a tough question to answer, and just kind of a follow on, because you made the reference to colonoscopies and sort of using AI to identify folks that might be at risk and would benefit from a colonoscopy. And as somebody who's heavily involved in being at the forefront of different cardiovascular tech, are you seeing ways that AI is being used in your field currently that you're excited about, or something that's kind of coming? It's coming soon.
Yes, it is happening. It is here. It's already happening. It's exciting. Whether it is characterizing the significance of stenosis of a blockage in terms of anatomically, that means how much percentage stenosis is there, and in terms of physiologically, evaluating the blood flow beyond the just based on the angiography, just based on the one angiography film. It's here. There are other tools under development that will play a role. We have AI used in implanting valves, so we can recreate a three-dimensional model for an individual patient's anatomy. If I'm changing their valve today, and if that valve fails 10 years from now, if I have to change that valve again, I can implant those valves virtually in a three-dimensional model and see what it would look like and would it work. And there are a lot of nuances. That's a very complex question, but the technology is here. It's here, and it's a starting point.
Yeah. This is great stuff. And I know that we just kind of scratched the surface in terms of the different innovations you've been a part of. It'd be fun to have you back on in a year or two and see kind of what new things you've gotten your fingers into. But Dr. Kintur Sanghvi from Virtua Health, I want to be the first one to thank you for sharing both your time and your story with us today. I really appreciate it.
I would like to be the second one to say thank you for the opportunity to talk to you and your audience, and hope our conversation can inspire some people to live healthy, some people to change their lifestyle, some people to seek help for their medical condition to their doctor. And hopefully, if we can even prevent one stroke or one heart attack, it's a big win.
Love it. Folks, that's a wrap on another episode of the Inspired Stories podcast. Thanks for learning with us today.